now we'll be discussing about the drugs used in disorders of coagulation. Now this classification has 5 different classes, which are procoagulants, anticoagulants, antiplatelets, fibrinolytics, also called as thrombolytics, and antifibrinolytics. Now in procoagulants we have vitamin K, fibrin, thrombin, and adrenaline. So now these come under procoagulants. In anticoagulants, we again divide this into 3 parts, which are oral anticoagulants, heparin, and low molecular weight heparin, also called as enoxaparin. Now here the oral anticoagulants, we have Warfarin, we have dabigatran, and then in antiplatelets we have aspirin, abciximab, third one dipyridamole or dipyridamole, and in fibrinolytics, also called as thrombolytics, we have streptokinase and urokinase. And in antifibrinolytics, we have EACA, which is epsilon amino carproic acid. And then second one, aprotenin. So these are antifibrinolytics. So in total, this is a flowchart of drugs used in disorders of coagulation. We'll be discussing in detail about the heparin. So when we come to the mechanism of action of heparin, normally we have plasma antithrombin 3, which degrades the action of thrombin and clotting factors. But when the heparin binds to the plasma antithrombin 3, it makes a complex. And then it increases the reaction or the action of plasma antithrombin 3 into 1000, degrades the thrombin and clotting factor 10A and 9A at a faster rate. Then what happens? Fibrinogen will not be converting into fibrin and results in an anticoagulation effect. So now this is a mechanism of action of heparin. We'll be discussing about the pharmacokinetics of heparin. Heparin is not effective orally. It is given intravenously or subcutaneously. And heparin is contraindicated in intramuscular because it forms hematomas in the muscle. And its peak action is observed after 5 minutes or 10 minutes after administration. And it returns to clotting time. The action of heparin leads to 2 to 4 hours, and the normal clotting time returns after 2 to 4 hours. So heparin action is monitored by APPT. Plastin thromboplastin time. Heparin is monitored by APPT, and heparin is metabolized in liver by heparinase. So now when I come to the adverse effects, there is a mnemonic H to the power of 6. So there are 6 H's to remember the adverse effect of heparin. Heparin induced thrombocytopenia, which is decrease in the platelet count. And hair loss, alopecia, which is reversible, the hair can regrow, and then hemorrhage, and then hypersensitivity reactions, hypoaldosteronism, which leads to hyperkalemia. Now the hyperaldosteronism, which leads to, in turn, these two are interlinked. While it causes hypoaldosteronism, it also causes the hyperkalemia, which is increase in potassium ions. So now what are the adverse effects of heparin? Hair loss, alopecia, hemorrhage, hypersensitivity reactions, heparin induced thrombocytopenia, hyperaldosteronism, which results in, this is not this is hypoaldosteronism, which results in hyperkalemia. So now these 6 are the only adverse effects the heparin have. And now when I come to contraindications, heparin is not used in bleeding disorders, hypertension, thrombocytopenia as mentioned earlier, hemophilia, cirrhosis, ulcers in gut, renal failure and neurosurgery. So it is contraindicated to bleeding disorders which is related to hemophilia, bleeding disorders, hemophilia, cytopenia, hypertension, cirrhosis, ulcers in gut and renal failure. These three are visceral and these related to blood. So bleeding disorders, hypertension, thrombocytopenia and hemophilia. While coming to the liver, gut and kidney related problems, cirrhosis, ulcers in the gut, renal failure and neurosurgery. So now this is about heparin. Now if we talk about the low molecular weight heparin, example enoxaparin. So now the low molecular weight heparin is obtained by chemical or enzymatic treatment of standard heparin or unfractionated heparin. So now, unlike heparin, low molecular weight heparin only inhibit 10A clotting factor, whereas heparin would inhibit the 10A and 9A clotting factors along with thrombin. But here, the low molecular weight heparin only inhibits the 10A clotting factor. So now, what are the advantages over heparin? Of low molecular weight heparin? It has a better bioavailability compared to the heparin. It has longer action, and the main advantage of low molecular heparin is it has less interaction with platelets, which results in less risk of bleeding and less risk of thrombocytopenia. It also has less antigenic property. The risk of osteoporosis is also less in low molecular weight heparin, and also we don't have to need to continuously monitor the low molecular weight heparin levels. So, and also clotting time. We also don't need to always measure the clotting time when the low molecular weight heparin is given. Now this is about low molecular weight heparin and on a very short and brief detail. Let's talk about one of the oral anticoagulant, which is warfarin. Warfarin is only used in vivo because it interferes with the synthesis of vitamin K. As we don't have vitamin K in vitro, we don't use warfarin in vitro. The mechanism of warfarin we'll be seeing now. So, glutamic acid will be converting into gamma carboxyglutamic acid in the presence of gamma glutamyl reductase. So now, when this gamma carboxyglutamic acid is produced, it activates the clotting factor 2, 7, 9 and 10. So now warfarin is given. So now what it does is it's go and set on the vitamin K reductase. So the vitamin K synthesis is stopped. So now there is no secretion or there is no passage of vitamin K from vitamin K reductase to the gamma glutamyl reductase, so that it decreases. In turn, it results in decrease in the gamma carboxyglutamic acid, which results in the suppression of clotting factor, suppression of activation of clotting factors. So these clotting factors are decreased. So it results in anticoagulation. So now this is the mechanism of action of warfarin. Now when I come to the kinetics, 99% of the warfarin bound to the plasma protein and orally well absorbed. And adverse effect, the main adverse effect is hemorrhage. And now minor adverse effects which are rare are epistaxis and bleeding gums. Epistaxis is nothing but bleeding of nose. The blood comes out of the nose. So epistaxis and bleeding gums are rare. Episodic epistaxis and bleeding gums can be seen, but they are rare. Now, antidote of warfarin is, if warfarin is given in a higher rate, it leads to toxicity, no? So we need an antidote for it. Vitamin K oxide is an antidote which results in synthesis of clotting factor and reversing the mechanism of warfarin. So as the clotting factor is produced, the warfarin action is suppressed. So the antidote of warfarin is vitamin K oxide. So now this is a brief discussion of warfarin.